laparoscopic appendectomy here on my brother. We're gonna pretend that I have on the appropriate PPE, mask, hat, goggles, everything like that. So I've set up my back table and have done a full count of all my instruments, sharps, sponges, everything like that. We did a full count just in case it was a possible open. So I did all that prior to starting the procedure. I'm going to be using a lot of my kitchen stuff, some little weird things here and there. So as you can see, he's in the supine position. He'll be slight Trendelenburg here in a little bit. He's under general anesthesia. Chloroprep was used from the chest to the pubis, side to side, covering the whole abdomen. I used 4 towels to square off the incision sites, and a lap drape was used. And all my cords and stuff have been thrown off. So to get started, pneumoperitoneum is established. Depending on the surgeon preference, a Varus needle or a Hassan trocar is used. In this case, I'm going to use a Hassan trocar. Let me use a little wooden spoon here. Along 10 millimeter Hassan trocar, along with 2 other 5 millimeter trocars. So before the incision, the surgeon may use local, and I'm going to use this little pin here and inject local. Excuse me. So using the 15 blade, I'm going to make an incision at the umbilicus down to the fascia, and sometimes the fascia will be separated using hemostats. Oh, anesthesia. Okay, we're good. And sometimes after, where's my hemostats? Here they are. So we're going to separate the fascia using hemostats. And we're going to apply 0 Vicryl to secure the fascia and the Hassan down. This was used for anchoring. And while applying the suture, a lot of times the surgeon will want the first assist to retract. And we're going to use these little deer antlers to retract. And once the Hassan is secured, the insufflation tubing is attached to the sheath of the trocar, and the abdomen is inflated with CO2 to provide more space for the surgeon for better visualization during the surgery. Blow up your belly. Blow it up. Okay, good job. So once the Hassan is secured and everything is in correctly, the rigid scope has been white balanced to ensure that we get the appropriate view and all the pictures and everything. And we're going to insert this scope, which is a 0 degree 10 millimeter rigid scope. We're going to insert it into the Hassan, and we're going to explore the abdominal cavity to make sure that the appendix is in the correct spot, and make sure that it is, keep your belly inflated. And we're going to make sure that it is still inflamed and that the patient does have appendicitis. Obviously they do if they're in surgery. So during the case, while the camera is in, they're going to also check and confirm the sites for the next trocars. So we're going to use that same 15 blade and make the other incision sites, which one is going to be in the right subcostal area, and then the other one's going to be in the midline suprapubic section. And that one is normally used for traction to not do any type of damage to the bladder. So once we got those incision sites, sometimes the surgeon will use some hemostats and everything to separate the fascia. It just depends on if the surgeon wants to do that or not. So once we got those incision sites in, we're going to use a wooden spatula, but a 5 millimeter trocar to put the trocars in. And once again, if the surgeon wants to inject local before the incisions, he will do so. So most of this time, we're going to put the grasper in the bottom one because it is the traction one. So we're going to use these tongs and put in there. Make sure it's tongs without teeth. We're going to put in there, and we're going to grab the cecum, and we're going to pull it back and retract it. So at this time, the surgeon will ask the anesthesia to put the patient into Trendelenburg, and he might also want the patient tilted so the small bowel is falling away from the side that the appendix is on. So the small bowel will want to be falling away from the right side. So we have the camera in, we have our graspers in, and at this time the surgeon might ask to change the 10 millimeter scope out for the 5 millimeter scope so we can put the clip applier, which will be used here in just a minute, into the Hassan 10 millimeter trocar. So we're going to change those out. So this is our 5 millimeter rigid scope. We're going to put it into the subcostal trocar. So the surgeon will ask for the clip applier. The first load will be a blue load, and then the surgeon will get 2 more loads, and those loads are going to be 2 blue ones. During the transition of those, we will wipe out the excess clips that's in there and put those like on a Raytech or something. So a laparoscopic bovie will be inserted after the clips are applied, and it will be inserted through the 10 millimeter Hassan, and the clip applier will just be tossed away because we won't use it again. So the laparoscopic bovie will be used to dissect the appendix away from the cecum, and once that is done, we'll use the graspers to hold onto the appendix, but then we will insert the bag to receive the appendix in, which we're going to use a Ziploc bag. So we're going to use the grasper to put the appendix into this, and then we're going to remove the Hassan trocar, and then we're going to remove the bag because we have to have the trocar removed before we remove the bag. So the appendix will be placed onto the back table, and we will toss that off to the circulator here in just a minute so it can be sent as a specimen. So once the appendix is removed, the surgeon will explore again, and he will also want to use the suction irrigator to be able to irrigate around everything, which we're going to use this little thingy, and we're going to and clean up everything inside. And then once everything is done, all trocars will be removed and the incisions will be closed up at the incision sites. So once again, we're going to use the 0 vicryl that was used on the umbilical region to do the fascicle on that, and then we're going to use this pink string for our 3-0 monocryl that will be used on the skin, and we will do that while using Adson's, and we're going to do that yada yada. So after all that is done, we'll use a wet and a dry to wipe off the patient and clean them up and everything. And once all that is done, Dermabond, which is going to be Elmer's school glue, will be used for Dermabond, and we'll let that dry, and then we'll use some Sari strips and put on there. And then once those are applied, then we're going to use some 4x4s and apply those as well to each of the incision sites. We'll also use a belly button ball, which will be a cotton ball at the belly button. And then after that, we will apply HIPAA-FIX to all incisions. So during closure, the final count was performed. It was just as sharps and sponges. We didn't do a full count again because we never did open the belly. So the patient will be took to PACU after they wake up in the OR, and they will be monitored in PACU for their vital signs. Hopefully have minimal pain and return to normal activities here in 2 to 4 weeks. And everything is done. Hey!